Thank you so much for your interest in our Ask the Doc event that was hosted on May 18th, 2021. Unfortunately, we did have some issues with recording the event from the very beginning. So I will reshare the beginning portion with the slides, and then we will jump into the recording where it picked up during the middle of some of the Q&A. You did not miss too much of the recording. There was about 15 minutes from the beginning that was missed. So I will do my best to go over that information with you today. And we look forward to recording an entire session for our next Ask the Doc. So my name is Stephanie Seville. I'm the Foundation Manager for the Pediatric Retinal Research Foundation. I'm very excited to coordinate the Ask the Doc event, and this event was made possible by all of the really generous donors and supporters of the Pediatric Retinal Research Foundation. So we welcome them to tonight's event and share a great appreciation, and welcome everyone else who is able to join us from all over the world. Today's event will talk a little bit about the Pediatric Retinal Research Foundation. We'll introduce our docs. A majority of the presentation will be focused on Q&A with the docs, and we'll have a brief closing message to share with everyone who joined us. So there's a few reminders before we get started, and just to let everybody know, we did record this event, and we are going to be sending out a link over email. We'll share it on our website as well as our social media pages. All of the guest cameras and microphones are automatically turned off. So everyone should be submitting questions through the Q&A button. You will not see attendees' cameras or hear their voices for anonymity, as well as to help keep the program going. We do want to mention a disclaimer that this event is for general information purposes only. It does not constitute the practice of medicine or the delivery of medical healthcare services, including the giving of medical advice. I'll give you just a moment to read the entire disclaimer for yourself, and just take note that this is not in replacement of medical advice. So please feel free to read the full disclaimer now. Now I'd love to share some information with you about the Pediatric Retinal Research Foundation. The mission of PRRF is to support the community impacted by blinding pediatric retinal diseases and champion the quest for cures through innovation. We have three major focus areas of our programs and services. The first being a great investment in translational research. We are really dedicated to bringing research from bench to bedside and ensuring that we have new innovations and opportunities that we're working on consistently. We also have the Ophthalmic Biobank, and you can learn more information about that as well as the research initiatives by going to pediatricrrf.org, and we'll share information about the biobank, how you can get involved, and the different benefits of gene sequencing that come out of the biobank. Lastly, we are expanding our community support programs in 2021, and we are focusing those efforts on educational advocacy, as well as resources and links available to parents, families, and those affected by blinding retinal diseases. As we continue to expand our programming for community opportunities, we would encourage you to check back on our website frequently, as we will be posting new things that we are introducing to the community at large on a regular basis. So please continue to stay in touch with us for more information about our community services. Now, without further ado, I'm very excited to introduce you to our moderator and our panelist, Dr. Tony Capone. Dr. Capone is a PRRF president, as well as an internationally recognized clinician, surgeon, and educator. He has co-authored over 300 publications in peer-reviewed medical journals, book chapters, and publications from clinical trials. Dr. Capone is currently a professor of biomedical sciences at Oakland University and a professor at the European School for Advanced Studies in Ophthalmology in Switzerland. He's recognized in particular as a surgical innovator, and he also serves as co-president of the ARC, which many of you know is a leading academically oriented private retina practice in the world. Dr. Capone completed his undergrad and medical degrees from Brown University, his residency at University of Pittsburgh, and fellowship at Emory University. Dr. Capone will be moderating today's panel discussion, and I am also pleased to introduce our other two panelists. Next, we have Dr. Michael Trese. Dr. Trese founded ROPARD, which was the predecessor of the Pediatric Retinal Research Foundation more than 20 years ago. He was president of ROPARD since its inception and has inspired to foster research into blinding pediatric retinal diseases. As many of you know, Dr. Trese is internationally recognized expert in the pediatric retinal disease arena with nearly 40 years of clinical experience. He has served in a number of leadership positions in ophthalmology as former president of the ARC and the Retina Society. Dr. Trese currently oversees the efforts to translate the results of research efforts at the Pearl Lab, which is a pediatric retinal research lab on the Oakland University campus. His focus is to translate research into drugs which can be used in the treatment of pediatric retinal diseases, a task he already accomplished with the development and commercialization of one of the drugs. He completed his undergrad education at the University of Michigan, his medical degrees at Georgetown, his residency at UCLA, and his fellowship at Duke. And last but certainly not least, I am pleased to introduce our final panelist, Dr. Kimberly Drenser. And Dr. Drenser is dedicated to promoting translational research in retina, making benchtop to bedside a reality. She has an extensive background in retinal research, which started with her PhD thesis, completed at the University of Florida and UC San Francisco. This generated a gene therapy for an inherited retinal degeneration. The foundation of this gene therapy has been developed into an FDA-approved therapy, which is now available for a rare blinding disease. While completing her ophthalmology residency at the Jules Stein Eye Institute, followed by a Retinal Fellowship at ARC, she continued to develop patient-focused retinal research for therapeutic development. Her development of the ophthalmic biobank allowed for the discovery of the role of WNT signaling, and specifically Norrin, in eye development and retinal regeneration. Dr. Drenser has over 100 publications in peer-reviewed medical journals, book chapters, and publications from clinical trials, including Nature and Proceedings of the National Academy of Science. She continues to treat children with blinding retinal diseases and extend research opportunities to collaborators at Oakland University and other institutions. Dr. Drenser is also a board member of the Pediatric Retinal Research Foundation. And with that, I am excited to turn it over to Dr. Capone to pick up in the Q&A session of our event.
Different impact. So if I can speak to what I think is the spirit of that question. We do a test for genetics. It comes back positive for fever. Are all positive tests for fever, do they all mean the same thing, or are there different genetic mutations that have a different impact on the findings in the eye, as well as the clinical course over the life of the patient? And Dr. Trese, why don't you lead us off?
If I'm off mute. I think that we have looked at this question for a long time, and Kim probably can give the best answer to this, but my impression is that we have some opinions as to which of the genetic mutations seem to have more severe forms of fever. And some of them even have other involvement, such as bony involvement with LRP5 and 6 mutations. In T-SPAN12, in our experience, although that's a rather common mutation, we have the impression that that seems to be more mild. but it doesn't really alter the treatment at this point, since we're not really involved in any type of gene therapy for this disease. Kim, do you have comments you'd like to add? Because you're certainly more versed in this than any of us.
Sure. I think the way that exactly how you described it is correct, and it's really easy to get bogged down on genetics and hoping that that's going to change the outcome or the management. At the end, fever is still managed by the clinical characteristics that we see. One of the best things with genetics is that it's allowed us to better understand how individual genes in a certain pathway may impact the future of the characteristics, how they'll express themselves. So as Mike was saying, I totally agree that, you know, we find that some of the mutations may have more milder impact on the vision or on the structure, whereas others seem to be more severe and need to have more frequent follow-up, more exams, more interventions due to their nature. We aren't at a point where we can say that we tailor any sort of treatment or management to the genetic specifics. But obviously that's one of the goals, is to be able to identify early on what the anticipated course of for that individual would look like, so that we can say, yes, you need to have exams every 3 months, or, you know, you're in a more stable situation, you can be every 6 months, and what to anticipate with that. So I think that we're getting there with the genetics, but we're a long way off from using it in the way that I think most patients would want it to be used.
So I'm going to probe a little bit more granular aspect of this for those who are interested in science, and then we're going to expand it to more general. So Kim, can you speak to the specific sort of structure function issue that your work has revealed with regard to the Norrie's disease gene and the influence, so genes are translated into proteins. Dr. Drenser has done some work with regard to specific genes and their impact on specific protein translation, and therefore the severity of disease. Kim, can you give a...
Yeah, so one of the things that was of interest early on when we started doing the genotyping across the spectrum of different patients with fever was that we noticed that certain patients tended to have more milder forms with less leakage. And so what we found was that some of the receptors, when they're altered, when they're mutated, they break down the integrity of the vessels more regularly. And so we seem to see a lot more bleeding, lipid, exudation, whereas genes that are more involved with what's called the ligand or the activating protein, so and that falls into Norrin or T-span12, which is actually kind of chaperoning Norrin to its shuttling it to its correct receptor. Those tend to actually have oftentimes more stable progression, because they don't break down the barriers as much. The vessels don't grow, and they can have lots of folds, and they can certainly still have severe vision loss from it, but they tend to be a little bit more stable in nature due to the fact that they aren't destabilizing the vessel integrity itself. And so that's been one of the biggest areas that I think we found helpful. And because of that, we've recognized that we can actually modulate potentially this pathway by modifying the way we activate it. So if we make a protein that looks and acts like the ligand Norrin, then we can actually override many of these deficits, whether it's in the receptor complex, if it's a Norrin mutation itself, by adding in normal Norrin, we can actually overdrive it as well. And that also goes for the T-span12 mutation. So this is one of these strange things where, by understanding that, we realized that we had a pathway that we could uniquely modify. So I think that that's the most exciting thing that we're seeing with the genetics.
So to step back then, so thank you. That's for any of you sort of who are really sort of bio or science geeks on the call. We can get you publications in that regard. If you just reach out to us, we'll be glad to send that to you. To step back at sort of how do those discoveries happen? That's really the product of having the genetic information drawn from the biobank, correlating it with all the clinical information we have, and taking a look at what mutations have, you know, more profound impact than other mutations. So to step back generally, the next question is specific to fever, but I think it's really a good general question, and that is, you know, how many? We'll start with fever as an example, but we could talk about schisis or Nori disease. But let's talk about fever since the question is about that. How many fever genes have been identified, and in what percentage of patients do you get a positive genetic result? You know, so we have everybody presumably has fever because they all have the clinical findings of it, but the genetic results only come back positive in a certain percentage. What percentage? And how many genes have been identified? Kim, that's going to be to you too.
Yeah. And that's where I think genetics gets very frustrating, is that when people get tested and they have, let's say that they have a very classical finding of fever by their exam and angiography, only 40 to maybe 50%, depending on the study that you're looking at, will come back with a positive identification of a mutation. It also gets more frustrating when you look at the cascade of genes. So there are 4 well-described genes that make up the either ligand or receptor or co-receptor. And so that's the neurin or the NDP gene, which acts as the ligand to activate. TSPAN12, which is really kind of a co-receptor / chaperone and helps to bind neurin and dock it to its appropriate receptor complex. And then there's the 2 receptors, frizzled 4 and LRP5. And those have been the most studied and the most characterized. There are a smattering of other genes that have been identified and are less well characterized. So another one is called zinc finger 408. When you hear a name like that, it usually means nobody knows what it does. And it's unclear exactly where in that cascade it falls. The most characterized one with the 4 proteins is very specific to a signaling transduction pathway called Wnt signaling, and that's where the majority of the research has fallen. There are other reports. So another one that comes up a lot is KIF11. KIF11 again is very poorly characterized. It has a lot of the phenotypes of fever, but it's unclear where or if it even falls in that same pathway, or if it's affecting maybe a downstream cascade that interacts with the more traditional Wnt signaling pathway. And then a smattering of some other examples of, well, TGF-beta receptor has been identified. The end protein in one of the cascades is beta-catenin, and the gene affecting that has been affected, but those are more like case reports. So there's certainly a growing number of genes that are being identified. And the goal, I think, with that information is really kind of threefold. One is to identify as many genes as possible, because with modern day genetics, we're able to do panels, which is really, really nice to be able to screen for multiple genes all at once. So we can kind of do this catch bag. 2 is to, and this is where pilot studies really come in handy, is to be able to do bench research to really take 1 or 2 genes in particular and find out what their role is in the disease process. And 3, as we get the information from those 2 areas, then we're able to start looking at therapeutics, and diagnostics and therapeutics that are more preferential.
So thanks, Kim. That's great. So you can see why Kim oversees our scientific initiative. You know, with broad strokes, there are about 6 genes that have been identified, and when we test patients, we get about half of them, as Kim mentioned early on. That doesn't mean, by the way, common question is, does that mean that my child doesn't have a genetic condition when they have fever? And the answer is no. It just means we haven't identified the specific genetic basis of disease. There may be isolated genes, for example, like the one gene thing that if you inherit it, you get the disease. It may be a combination of genes that in and of themselves are innocent, but if you get the pair or the triad or who knows how many, that all of them taken together end up giving you fever. So we are really kind of in our infancy in many regards. We're still largely in a, one gene, one disease kind of a diagnostic paradigm. And I think that that is undoubtedly overly simple. But we're getting better. Dr. Trese, I have a good question posed for you, if you would. It has to do with fundamentally how do we recommend children with pediatric retinal diseases are followed over time, largely with regard to frequency, and do you see children whose acuity improves as they age? Can you speak to that for us?
Well, I think that the regularity of examination seems to be really very important. And we see that often in the situation where children during the pandemic or with travel restrictions, we haven't been able to see for months at a time, maybe a year at a time. And those children can progress to a point that makes it much more difficult to manage them. And to a certain extent, all of medicine is a science and an art. And part of the art is trying to figure out what the timing of examination is. And in fever, in particularly because fever is a potentially active lifelong disease, follow-up is a very long time, lifelong. And we've come to a conclusion that most of the time, fever changes can be monitored at about 6-month intervals, seems to be safe. And we did that. We started off when we first started understanding the pathogenesis of fever and had the ability of doing wide field fluorescein angiography. We first started off screening those patients at 3 months and then discovered that maybe 6 months was safe as well. So some of it is subjective without any question. Sometimes it's very difficult to understand the progression of the disease. A little bit has to do with the genetics, as we mentioned before, whereas LRP5 and 6 mutations seem to do worse than some of the others. But all of that stuff has a little bit of subjectivity to it. But it is, in fever especially, it's very important to stay on top of it and to be watched at a regular interval. There are all other kinds of parameters dealing with other pediatric retinal diseases like Norrie's disease or congenital X-linked retinoschisis or Coates disease, and all of those need to continue to be followed because they can change, and a treatment can be mandated at different times along that path.
So, Dr. Trese, in your personal practice, does wide-angle fundus imaging alone suffice, or do you feel that fluorescein angiography is an important part of the ongoing evaluation?
Oh, fluorescein angiography is absolutely critical. It wasn't until we had fluorescein angiography that we really understood the progressive path of fever. Same as I think can be spoken of Coates disease and other pediatric retinal diseases. I've often said I've probably seen as much fever as any doctor anywhere in the world, and I cannot look at the eye and tell you what should or should not be done relative to fever care without fluorescein angiography. And it's a tremendous benefit, the addition of wide field fluorescein angiography to care of all of these diseases.
Yeah, I would agree with that. That's been pretty much our standard. And you kind of, you don't know when a disease is going to become active. So all of these diseases are lifelong diseases, and they may smolder and be quiet for a while until they are not quiet. And it's always easier to cut something off at the pass than it is to catch it from behind. So that's kind of our notion for ongoing, fundus imaging, both color fundus imaging and angiography, is we really kind of want to keep our finger on the pulse of things. There's a great question about the reach of the foundation. In other words, is our foundation do we really just reach the folks who are patients only at ARC? Or is there an initiative and is there success at reaching beyond it? And Hughes, Stephanie Seville, who will come back on and speak to that.
Yeah, thank you, Adam, for your question. It's a great question. We have a tremendous amount of international reach with this work, and I love seeing all the representation from different countries weighing in for information and resources and support. So to address some of those needs throughout the world, what we're currently doing is really bolstering our social media content. So we're hoping what you're going to see in the next year is a lot more activity on the PRRF Facebook and LinkedIn pages. It's a great source where we can share relevant information. We can connect with people on a personal level throughout the world and answer your questions in real time and get information to you. In addition to that, we are also expanding our Sightlines newsletter. We're sending that out much more frequently than what you've seen in the past. And we have a problem where we have more information than we could possibly fit in the different issues that we are publishing. So if there is specific information that you would love to see, please share that with us. But we are trying to address the great need to spread awareness, not only for the foundation, but just the information that's available to people that are looking for answers, essentially. And we need your help to do that. So please share your thoughts, your ideas, engage with us, follow us, become our friends, all of those great things on all the channels that we're currently on, trying to support the community at large.
Thank you, Stephanie. And I think I'll reinforce the plug for Sightlines. For those of you who don't get it, it comes to you by email. And you'll have your finger on the pulse of what's going on in research, what's going on in the community, what events we're having, informational and fundraising, of course, because without fundraising, the research can't go on. And we also talk about something that we put under the umbrella of the term educational advocacy, and that is, fine, I'm glad you guys are doing research, and I'm glad you're raising funds and having webinars like this, but I have a child who has one of these conditions, and I have the task of raising that child, and I have a number of questions about what's going to happen with regard to my child going to school if their vision is in 2020. What's going to happen with regard to my child getting to drive, going to college, getting a job, things of that nature. And so we have folks who are part of the foundation family who've taken children from infancy to adulthood and every step in between. So that's part of, I think, the value add, if you will, to Sightlines. It just kind of keeps you plugged in, and it's pretty easy from your all's perspective. Kim, I have another question for you from the audience, and it ranges from a sort of a broad strokes question, like when will there be a cure for things like fever and retinoschisis, and maybe more specifically, if you could hone the question, what is the application of kind of current technologies that get a lot of press, like CRISPR technology, to addressing, mitigating these conditions for young children?
So why don't we start and work our way backwards a little bit? So, I'll address, because it gets a lot of press right now, CRISPR technology. So CRISPR technology, as I'm sure many people have read, is very exciting because you can basically, it's like having like a little stitch fix. So you can direct a fix for the alteration in a specific gene and fix it that way. And I actually think that CRISPR technology is probably going to be used a lot in medicine in the not so distant future. That being said, CRISPR technology also has a issue in the fact that it's not well studied in how it's going to work in a human. And we have a pretty complicated genomic database that we need to be careful that if it finds a similar sequence and also alters something, you could be deleting something, you could be causing a cancer. So a lot of times those technologies sound really great and get a lot of media, and then they kind of lose their excitement because they're a good 5 years minimally before you're even hearing about it getting into clinical trials. And very similar technologies to what happened with early day gene therapy and why we don't hear as much about it. There was so much hype going back actually about 25, 30 years ago. And it was a little hyped beyond its day to be revealed. And because of that, there's a lot of disappointment in what happened. We're finally now just starting to see gene therapy. So, Luxturna was the first for retina that it's actually still the only one for retina with FDA approval as a gene therapy for a blinding disease. It's unbelievably specific, and that's always been the problem with gene therapy as a whole, is that it's what they call designer medication. So everything has to be tailored for a specific, not just gene, but oftentimes that little very portion of the mutation. And that's the same problem that CRISPR technology is having, because we're not dealing with just one gene. We're dealing with lots of genes in a cascade and lots of different mutations that occur within a single gene. So you're really looking at thousands of permutations of alterations that can cause the same eye disease. So for fever, and that's one of the reasons why I was really excited when we were really able to we did a long time ago a phenotype genotype with our biobank information to try to better understand, could we correlate what gene was affected, and furthermore within the gene, why in some people we see such severe disease type and other people we see so much more minimal disease type. To better understand that, by understanding a pathway, you can actually come up with a more universal treatment. Oftentimes by overriding that pathway, you can either turn it on upstream or you can turn it on downstream. And so I think from a treatment standpoint, that is always a more tenable therapeutic than a gene-based or gene-altering based therapy. I think the only quote unquote true cure for something that's an inherited disease like fever is truly a gene alteration, where you are able to completely, most of the time you have to get rid of the altered gene. Sometimes you can actually just add a supplemental gene that overrides the function. But I think those are going to be few and far between from a therapeutic standpoint.
Thanks, Kim.
Sure.
So, Dr. Trese, there's a question that I think that you're very well positioned to answer, and that is, can you speak to how, what trends have occurred in retinopathy of prematurity in the last, say, 15 years with regard to its incidence, its severity, and how it's treated? I know you could give a 3-hour lecture on this topic. So
yeah, right, exactly. But let me just comment on that last thing a little bit. I think it's one of the things about gene therapy for fever is that generally the first case that's found, called the index case, has got tremendous anatomic changes that a gene therapy may not be able to repair. And parents may have the impression that if you were to do a gene therapeutic in an eye that already was tremendously anatomically altered, that it might be therapeutic. I'm not sure that's the case. So in terms of retinopathy prematurity, since I was going to say, and I will say it, since I am old enough to have lived through this entire thing, what happened was many years ago, it made no difference if children were screened or not screened because we had no idea how to treat them. And then through the understanding of a classification system, we could actually perform beneficial studies, therapeutic studies, relative to the intervention for retinopathy prematurity. So even though the incidence of premature birth may be increasing, retinopathy prematurity still is coming under pretty good treatment paradigms based on not only treatments that we've used for many years, but also more current drug therapies that may be beneficial in some circumstances. So actually the treatment for retinopathy prematurity, even in my professional life, has gone from being failure rates of 50-some% to failure rates of close to 2%. And that is a huge, huge accomplishment. And it's based on the work of a lot of people, 3 of whom are here today. And it really is, it's tremendously rewarding to see children that you know would have been blind back in clinic, even now, who have vision good enough to drive a car, good enough to attend college without any type of visual aid. It's become a very rewarding part of ophthalmology and retinal care.
Thanks, Dr. Trese. So I'll pick up the thread that you carried from Kim. You know, the question about gene therapy is a common one, understandably, because that's the core abnormality. And what if you just fix the core abnormality? To Dr. Trese's point, if that genetic abnormality has resulted in severe alteration of anatomy, correcting that gene defect isn't going to fix that. You know, the horse is already out of the barn. So we're really not going to be able to impact on bilateral complete retinal detachments with gene therapy. There are other things that we can talk about, but gene therapy isn't going to be the avenue for that. However, if someone has a condition that is milder, it's conceivable that gene therapy may be able to positively impact that person. And so to that, Dr. Drenser, can you give us a little bit of a summary on the state of the art with genetic therapies for X-linked retinoschisis?
Yes. So it's funny. I was going to mention that one of the best genes that, that is a great target for gene therapy. And I would actually argue not CRISPR technology, not, trying to fix the small mutation, but actually just gene replacement therapy is actually retinoschisis, X-linked retinoschisis. The correlation between what you see when you make the clinical diagnosis by examining and doing diagnostics is 94 to 96% of the time correlates with a mutation affecting the RS1 gene. So that right there is the number one thing you look for gene therapy, for something that's going to be amenable to gene therapy. So that in itself is huge. Now there are, I think we're down to one. We had 2 companies. One was the National Institute of Health, or National Eye Institute. And then there was also a commercial company that was looking at gene therapy for retinoschisis. They were both using the same vector. So when you talk about gene therapy, you have to figure out how are you going to introduce a gene into a host cell. So the host here being human and being a retinal cell. How do we get this little piece of genetic information into the human eye and then have it integrate either into the chromosome itself or sit isolated with what they call a plasmid, or an external chunk of DNA that can replicate that protein within that cell. So the most common ways of doing this is in nature, we have a great vector that does this, and it's viruses. That's what viruses do. They can't live on their own. They need the host cell in order to replicate and survive. So by re-engineering viruses, you can actually get the virus to infect a cell. But you can fill that virus, you eliminate the viral DNA and you fill it with the DNA of interest. And then picking the virus is another thing. So for most applications, particularly in the retina, they've always used an adeno-associated virus. And the reason is because it integrates into non-dividing cells. And the retina is formed as a fetus and completes its development shortly after birth, about 3 months after birth. And then it's really kind of in a holding pattern. So you don't have a big turnover of cells. So there aren't many viruses that actually like to infect non-dividing cells. AAV, adeno-associated virus, is also not very pathogenic. People don't get real sick from it. 80% of people are positive for AAV and would never even know it because it's really a very mild virus. So that also makes it a really great vector. but it's also not a robust vector. So that gets to the problem with the, in my opinion, the existing options for retinoschisis in the gene therapy is that I think this is a, well, I know this is, I worked on this as a PhD, and it's the one that's in the Luxturna. It's the same viral vector that's used for the Luxturna for Leber's congenital amaurosis. You actually have to put that viral vector right up against the cells you want to infect. It, by definition, is a surgical intervention. And unfortunately, the trials, both companies looked at being able to try to do this as an office-based technique by injecting into the center of the eye, into the vitreous gel, and hoping that the virus would be robust enough to get to its target cells, but it just isn't. So I think that, and I'm hoping, I know that there's still a push to get the RS1 gene therapy. It's in clinical trials to try to get it into a commercialized form. I'm hoping that that's going to continue pushing forward, because I think it's a very, very viable option for really everybody who has an identifiable mutation and has X-linked retinoschisis.
Yeah, that's great, Kim. Thanks. So I think you can get from this conversation, to step back from it, a couple quick points. So, gene transfer therapy, or gene therapy, as we mentioned, isn't going to affect somebody who has severe anatomical alterations. The only way to do that in candor would be to identify the abnormality at the embryo phase and edit the genetic material of that embryo so that those genetic abnormalities did not occur during development, which is when many of them occur, for example, in the more severe cases of fever or Norrie disease or retinoschisis. For the milder diseases, the genetic therapy does offer some opportunity to mitigate the severity and make it so that patients with retinoschisis and, say, macular abnormalities that are treated when they're young might not have the decline of vision to 2040 or 2060 that typically occurs when they are, 40 and older, if they're treated, for example, when they're 10, 15, or 20. So it's a modulating intervention, kind of currently, as we conceive of it, and not so much a disease elimination therapy, which again would almost require embryonic level intervention. And I think just to speak to this issue of the vector that Dr. Drenser is discussing, I think the simple way to think about viral vectors is that the virus, basically, as Dr. Drenser mentioned, has an external part, and then that houses or carries the genetic material that the virus injects into the cell of the human, that then turns that cell into a factory to make more viruses. What we do for gene therapy using viral vectors is we just take the outer part of the virus, and as she mentioned, we take out the viral genetic material. So you basically use the viral shell as an injector. And in these viruses vary with regard to how efficiently they attach to cells, how efficiently they will inject the material, and so on and so forth. And I think, Dr. Drenser made a kind of nicely spoke to this issue that a lot of viruses aren't attracted to cells that don't replicate, because that's not where the money is for them, right? They want cells that are rapidly reproducing so they can turn them into highly efficient factories, and then their progeny and their progeny after that. So these are all kind of nuances to gene therapy that maybe help explain why it doesn't all happen tomorrow. There are a lot of things still to parse. That was a great discussion, though, about retinoschisis. Thank you, Kim. So for Dr. Trese or Dr. Drenser, there's a question on Coats disease, and a parent whose child has been treated with anti-VEGFs, Avastin and Lucentis, for a while, quarterly, and then the doctor has recommended stepping back from injections. And so I think the spirit of the question is, what's the role of anti-VEGF therapy in Coats disease? And if there is a role, how long to use it for?
Ladies first.
All right, so so Coats disease, to me, it at least for me, is very, very frustrating. And I think that, unfortunately, sometimes people lump Coats disease and fever as similar vitreoretinopathies.
Actually, Kim, can you, that's one of the questions. Can you split that here? Can you distinguish Coats from fever briefly, and then go into the answer about Coats and the anti-VEGFs?
Yeah. So the first thing is that I'm going to actually start with what people may have heard first. So I have maybe a handful or fewer reports of Coats disease with mutations that are classically found in fever. And I have reviewed every paper that has ever done that, and nobody has ever shown an angiogram or shown the other eye. They've always shown the affected eye. And I think that that's a real problem, because fever is a bilateral but asymmetric disease. And oftentimes I have had experts fooled when they didn't get an angiogram. Oftentimes you cannot identify that there is a bilateral component in what appears to be a healthy eye. So I don't believe any of those reports if they can't show me an angiogram of the fellow eye. And I think those are misrepresentations. Now, the only way that you would be able to truly identify genetics in Coats, and we have a pretty big database of Coats, and none of our Coats patients have had a genetic mutation when we've scanned them for fever mutations. So in our hands, when we do angiograms for identifying this, we don't have a single one. They may have something called tissue mosaicism, which is that whereas fever has generally what's called a somatic mutation. So every chromosome in every cell in your body has that same mutation. It just happens to be very, very important for the development and maintenance of the retina. So you see the eye disease there. Coats more likely represents a sporadic alteration during development. So you have a fetus that's growing normally, and then for whatever reason, as the eyes are starting to develop, the one eye gets a sporadic mutation within that little ball of cells. So the rest of the body doesn't have the mutation, can't pass it on, doesn't have any effects of it. The only way to know that, unfortunately, is you actually would have to take tissue from a Coats, not just tissue, you'd have to take retinal tissue and retinal vasculature and do the genetic testing on that to look for that mosaicism. So I think that that's a big difference that some people just quite frankly wrongly lump them together. That being said, I think that there is one of the similarities with some types of fever and with almost all types of Coats is the exudation, the lack of integrity in the vessel walls. And what anti-VEGF medication does is it transiently, for a very short period of time, shores up those vascular walls. So intuitively, it makes sense to use anti-VEGF. The problem is that it's not fixing the problem. So it's a little bit like having a leak where you have a temporary adhesive in your sink, but as soon as the adhesive goes away, your sink is leaking again. It's kind of the same sort of problem. Or, you know, fix a flat. It's not fixing your tire, it's just getting you to the gas station to get a new tire. So it makes sense that you can't really necessarily get off of anti-VEGFs because you're not curing it, you're just trying to control the symptoms of it. And so I think that that's one of the reasons why Coats can be very, very frustrating. Personally, I also think that some of the exudation in severe Coats is less receptive to the anti-VEGFs. And I think that the degree of severity of Coats probably correlates quite closely with the breakdown in the integrity in the vessels. And it's just like, you know, throwing stones at an army. You know, you might hit a couple people, but they're still marching through. And so that's why I think that they're very, very different. And personally, I think Coats is very frustrating because of that.
Yeah, so I would agree with Kim. I would say that anti-VEGF therapy, you don't get a big bang out of it. You get some impact, and you get most of that impact after the first few injections. And after that, there's really not much additional impact.
I gave a lecture on Coats disease last week to two of our fellows who are particularly interested in peds. And my point was that your goal of treatment is to destroy the leaking vessels. And what Kim was saying, and obviously she's very well trained, but when Kim was saying about the fact that until you destroy those vessels and all you do is modulate leakage, you're not really dealing with the disease. And so the treatment of Coats, when you start, one of the things I tell the fellows all the time is when you're treating Coats disease, you have to make sure that the parents understand that this is not a one treatment disease. This is going to often require multiple treatments. And the goal of those treatments are to destroy those vessels that do the leakage, because very often, even though they have some avascular retina around them, which may be a stimulus for VEGF, which anti-VEGF may help and treat, unless you have destroyed the vessels, that leakage can come back. And it's a very different management than it is for fever. And it can be a very frustrating disease, but it also can be a manageable disease if you approach it with the fact that you need to destroy those telangiectatic vessels somehow by cryo or laser or some type of direct damage.
Yeah, one point that Dr. Trese is making, I think, very well is that when your child has Coats disease, you enter a long-term relationship with the retina surgeon or the retina specialist taking care of you. So we have a number of other great questions, and unfortunately, we are running really to the end of our time. We need to wrap up. I'd like to thank all of you who have signed on this evening. I think this is the kind of event that we would hope to be able to do again. And I'd like to thank Dr. Trese and Dr. Drenser for participating this evening and answering the questions for their insights and their contributions. Many of you have asked how you can get involved and support the work of the foundation, even in the chat this evening. On your screen, you'll see 3 volunteer opportunities currently available. We are currently forming a family advisory committee made up of 6 to 8 individuals representing the diseases supported by the foundation. This committee will help drive our strategic initiatives. It is very much integrated with our board, so it is an impactful way to become involved and ensure that families' voices are heard and represented in our strategic programming. We also welcome families to become ambassadors for the foundation, sharing your journey to provide inspiration and awareness for pediatric retinal diseases, whether it's speaking to families who have a newborn, who have a condition that you're familiar with, or becoming more involved in our social media initiatives. Finally, we'll be having our 3rd annual Hope for Vision Walk this year, and currently looking for committee members who are interested in helping us plan the event. By virtue of the sort of Zoom culture, the event has grown from being a local walk to being really an international walk. So if you'd like to learn more about any of these opportunities, please reach out to our team at info@pediatriprf.org for more information. Lastly, I'd like to close out this evening's event by inviting everyone watching to stay in touch with us. This is all about, community. Without you all, we're sort of clinicians who just, see patients and work in the lab, but aren't in touch with the people that really we're hoping to have impact on. We have a lot of great activities coming up, and we would love to see you soon. So for more information on that score, take a look at our website, www.pediatriprf.org. If you haven't already signed up for Sightlines, there's a button at the bottom of our website where you can do so. There was also a question about making donations. There's a donation tab on the website as well. Lastly, join us on Facebook and LinkedIn by following, liking, and engaging with our posts. You'll find our pages by searching @PediatricRRF or the links on the website. Thank you, everybody, again, for your time, and have a great evening.
Thank you.
Thanks.